So my name's John Allan. My day job is I'm the Executive Director of the Mental Health, Alcohol and Other Drugs branch in Queensland, so I look after policy and things in Queensland. I want to welcome you all to Queensland and thank you for choosing to come to our wonderful state, perhaps for your first conference away while the panel gets here, so we're going to do that. As Susanna said, we are a bit late, and so the good news for you is that my complete instruction is that we finish on time, okay? And so whatever these people say, I'll make sure that they don't say it too much, and we will finish on time. For those who are worried about their planes, including members of the panel, that's what we're going to do. We've had a fantastic conference with a lot of fantastic ideas. The title of this talk is Implementation Barriers, the Next Steps. And what I've also got to ask the panel to do is to make sure that what we talk about is really something that's positive. And I've been given this instruction that it should be forward-leaning. I don't know if you know about the word lean in COVID. Have you ever been asked to lean into or to lean out or to reach in? Some of those words that used to just mean something like hanging around before COVID means a whole lot more. So we're going to lean forward to the future into this presentation, as Russell has asked me to do. And perhaps we might even reach that point of kairos. I love that conception. I was sitting there thinking about the root of that, whether that actually came from Christ or it came from chaos, but I'm going to go and look that one up. Around that. So what I'm going to ask everyone to do on the panel, rather than me read out the bios and so on, is very rapidly just introduce yourself. You've got 1 minute to 30 seconds to 1 minute for that. And then we're going to have a 3-minute thing about what you think are the main issues or the main issue in the overcoming the implementation barriers. Just one or two good ideas. We don't have to linger on what the barriers are. We've heard about them for 2 days. We want to hear about how to leap over the barrier. So we do that. So we're going to start at this end. Vicki.
Hi, my name is Vicki Langan, and I'm the New South Wales Health Promotion and Wellbeing Manager for NEMI National Community Mental Health Services. And I suppose my focus over the last number of years is to try and build into existing community mental health services health promotion activities and health promotion services because they just didn't exist, and we still struggle to make that happen. I suppose, yeah, and I suppose I work a lot with the peer workforce in NEMI and a lot of co-design, so all our physical health and well-being activities that we implement in NEMI are co-designed with consumers for consumers.
Not to the grand dame of our movement, Faye.
I'm Faye Jackson. I'm currently the General Manager of Inclusion at Flourish Australia. Have been a Deputy Commissioner for the New South Wales Mental Health Commission. Before that was a Director of a public mental health service. One of the directors, there were 5 of us. I was the Director of Consumer Care and Community Affairs. And before that, I was a peer manager, and before that, I was a peer worker. And the whole time I've been crazy and proud of it. So I'm a member of the Mad Pride movement, and if any of you here are people with lived experience who are not yet a member of the Mad Pride movement, get on board. What I think really is both the problem and the cure for our physical health not being considered important for those of us who have mental health issues. I think the base problem, with the same of every problem, I think, in mental health services, is culture. I think that there is a culture that in the community, a culture in services, that so long as we're quiet, not causing a fuss, then everybody's happy. I actually think that culture is killing us. I think that culture is destroying the opportunity for the council, for the community to have everything that we have to offer. And we want the opportunity to offer that. I think that if we have a culture that is open and understanding that we are valuable members of our family and of our community, then maybe They will want to help us keep our health well, keep us well. It's just so essential at the moment to keep us quiet. And they'd rather keep us quiet than keep us alive to the life expectancy of everyone else. So I think culture is at the base. Let's have a loving, inclusive, caring culture that's about whole of life, whole intergenerational and whole of health.
Thanks, Faye. Hand over to Andrew.
Thanks, John. Faye, good afternoon, everyone. My name's Andrew Watkins. I'm hoping Faye left me a little bit to talk about because that was kind of all-encompassing, I felt. I'm a nurse practitioner and have spent most of my career, along with many fine colleagues, developing the Keeping the Body in Mind program in South East Sydney Local Health District. And Russell will be very keen for me to also say that I'm an Equally Well ambassador. I think for me, when I think about this issue and public mental health services, my mind always goes to oncology. And I know there's been some references and comparisons to that during the conference. But, you know, one of the treatments in oncology is obviously chemotherapy. And I just want everyone to imagine what would happen if, in oncology, they never checked in with people about the side effects from chemotherapy. If they never said, all right, well, let's look after that. If they just said, you know, I'll go and see your GP about that. Or even worse, didn't even acknowledge it was happening. Because that's what happens a lot of the time in public mental health services. That's the negative side of a story. And, you know, we do want to focus on the positive. And I think what we've heard during the symposium is so many good pockets of practice that are occurring, and it's really heartening to hear how much, I mean, even compared to the last symposium 3 years ago, how much more has popped up and how much more developed some of the other existing ones are. It's really, really heartening to see. So that's despite the barriers, despite the cultural challenges.
And Carline?
Thank you. Hi, I'm Carline Johnson. I'm a general practitioner from Melbourne, and I divide my time between clinical work and medical education and primary care, mental health research and mental health advocacy. And so I guess the main thing I've taken away from today in terms of implementation is I think we've done okay training GPs. When we saw Sam Manga today, I thought I could be pretty proud that, you know, many of my registrars actually, maybe not quite as impressive as Sam, but they definitely have their heart in that place. They are taking up, you know, learning about lifestyle medicine. When I first heard about it as a grumpy old GP, I thought, oh, that's some other bullshit thing that young doctors are going to do to make money. But then I see people like Sam actually trying to apply these new learnings to help the people in his community. And I see lots of young GPs who are doing that. So I have great hope for the future. What I struggle with is attracting more like-minded people to the profession. And I think this comes down to what we talk about, the quadruple aim of primary care, which is focusing on the positive experience for the people who use the health system, that they get good outcomes, that it's efficient, you know, that we actually can afford the system that we've got. But the fourth part of the quadruple aim is also looking after the well-being of the providers. And I've heard a lot today about the problems in the mental health system. And what I hear the subtext of that is there must be a whole lot of really unhappy people who are mental health workforce in that system. And I guess for implementation, I think we have to try and work on this collaboration, which Tim touched on, working together for better outcomes, so that those people also can be renewed and work in their profession. So I guess that's another factor I'd like to think about in implementation.
Thanks. So we've heard about a couple of things. One's about culture. We always talk about culture. And then when we say culture, we think, well, how are we going to change culture? So that's one question for you. And the second one is that we've had a lot of good ideas. And one of the problems is you go to a conference to hear a good idea, but what actually happens when you take the good idea at home, it's still on a piece of paper in the drawer rather than actually implement it. And what are the barriers to that? So maybe the panel can just turn their kind of implementation thoughts to what are the things, or the one thing that you might do to overcome those implementation barriers to any of those changes. I'll start with one thing that I actually learnt last night. Were any of you lucky enough to go to the WHO launch of the Quality Rights Framework last night? international collaboration with the Director General of the WHO, with the Health Minister of Portugal and of France, supporting what Tim was quoting from the WHO Quality Rights Framework about respect for people and how to change. And that was actually a course that you could do. And when I was Chief Psychiatrist of New South Wales, I came and offered to train everybody in Quality Rights Framework in New South Wales for $10 million. And now, 7 years later, it's actually free online with an aim to train 5 million people in the framework around how do you actually bring human rights back into mental health, which is what Faye and others have been talking about. That's one example of what we could do. We're going to ask the panel, what's your thing that we would change to make those things about the culture and the human rights and that failure of implementing to be different? And we've all got an angle. You've already heard a bit about the angle, so I'm going to probably just start with whoever likes to start. But maybe
I'll go first because I only have one answer and someone else might say it. I think the human rights angle would be that you should fund mental health care in proportion to the burden of disease that it causes, because at the moment we don't, and that's not equitable. And if you fix that, you would get a long way to solving some of these problems. I know we're not allowed to talk about money, but at the end of the day, it should be proportional to the need.
Yep. Parity. So it's about 8% of the funding, 10% of the business and 15% of the morbidity, not counting the physical illness associated with the morbidity of mental health. So it is enormous, and it's twice the amount that's funded in proportion.
John, I probably need about 3 weeks to answer this question because
plane leaves.
It is one. It is one that's very complicated, and I think what we probably need to do is look at it through a socio-ecological lens, because it's multi-layered. If I focus on the area that I'm representing here, public mental health services, well, I've seen culture change, and to give an example, I spoke about being involved with keeping the body in mind. Part of the setup of that was the Keeping Our Staff in Mind program, which we rolled out before we rolled out Keeping the Body in Mind to adults. And the idea of that was to bring staff on board, give them an experience of what the interventions were like, because the large majority had not had contact with an exercise physiologist or dietitian and didn't know what those roles really did. So we achieved buy-in. We know it's tough being a clinician. There's a lot of change fatigue that goes on, because there's a lot of shifting deck chairs on the Titanic, as I call it. But there, what has been achieved in Southeast, and there's lots of other examples that have popped up, is real culture change. So on a smaller scale, it is totally possible, and you don't need the specific resources to do it first. Resources can come, but it's about dedicated people that want to make a difference. So you've got to maintain the energy, maintain the rage, if you like, and also get together with a group of colleagues that are going to support you and help drive you through, because there will be really tough periods.
Faye, Vicki, do you want to?
Yeah, I'm just going to follow up on that in relation to culture change. But I think I'm speaking from an NGO perspective. The people that work within NGOs are not there for the pay. They're there because they want to be there. And they're dedicated workers. A lot of people come with lived experience as of carers, currently experiencing mental ill health. And I think one thing that we could do is increase the peer workforce. And then you won't need to have to change the culture, because it will already exist in relation to making sure that physical health is on the table. But there's a huge difference when working in the, let's say, non-clinical and clinical space, and for an NGO to be able to, we're not going to change, we'll try, but I've noticed a huge difference when working in collaboration, which we are doing, with clinical services and with, let's say, national government bodies. There's a huge difference in relation to how they engage with you, but also the respect that they give you as a professional within an NGO service. So I think, yeah, that will be my positive bit in another little while, is how did we get over that? So, yeah.
What's the difference between them? What's between the services and the national bodies? What's the difference? Good or bad? Be honest.
Good or bad? Well, look, it comes down to very much the clinic. I'm not saying everybody has a place, absolutely, and we need to have our clinicians there, absolutely. But I suppose one of the examples would be one of the projects that we presented on yesterday around the older person's physical health prompt, and looking at the attitudes and the time from the clinical perspective in relation to, like, we don't have time to do that, that's not a priority for us. How do I get my staff to talk about physical health when they're not upskilled on that particular topic? You don't have to. You just have a bloody conversation about physical health. So, but it's really about that system change and building in that strength-based approach, the coaching conversation. Unfortunately, a lot of people working within the clinical setting don't possess or have the skills around coaching. And that's what's a huge difference between community mental health and clinical. Yeah.
Thanks. Faye?
I'd really like to not comply with you, John, and give you only one answer. And you're right, it's a week-long conversation, isn't it? But I do think, again, that it's all comes down to culture, and you shift culture with peer workers. People in designated lived experience roles shift culture because they shift the language. Language drives culture, and that drives outcomes. So I think that's a really important thing. But I think let's give peer workers Medicare provider numbers, and let's set up share care services in GP practices, and that where a group of people, a dozen people come together, all, we all take lithium, we're all are carrying too much weight. We all need to know more about nutrition. We all need to know more about our heart and relaxation and dancing and culture, and bring them together with the GP, psychiatrist, nurse and peer workers, and together they talk and all learn off each other. And then the doctor learns from the psychiatrist learns from the doctor. Not that psychiatrists aren't doctors, didn't mean to infer that, but they never check on our physical health, do they? So, that I've seen models of this working. I know this works. It works beautifully. It's a really good use of money. It's a really good use of time with really good outcomes. So the shared care model, where there are groups of people in with a GP, a psychiatrist, peer workers, works beautifully. And we have Flourish Australia, who I work for, have the psychiatry liaison model. I don't know if you've heard of that, where a psychiatrist and two peer workers go into, they're in a large GP clinic, and they just work with the people. The peer workers support the people with lived experience and the doctor, and the psychiatrist supports the doctors, and they support the people with it. And the outcomes are amazing. The GPs are loving it. Their mental health is much better. They're having much less burnout and everything. And the physical health and mental health of the people accessing those services has increased dramatically. They're simple models. We just need to put them in place. But cultures can stop them from happening.
So, fantastic work there. And it sounds like, to me, an old-fashioned self-help group on steroids, where everybody's getting something out of the arrangement. So what's the thing, you said we need to do more. What's the thing that's stopping us doing more? Why aren't we doing more? Is it just ignorance, or is it a payment barrier? I mean, Carline could probably speak to this a bit as well.
Oh, you're not asking me.
I'm asking you, but I'm also asking the panel as well. Yeah. What? Like, we need more, so why haven't we got more?
I'll take it from any direction. Again, I think it's culture, but it's also that doctors, anybody working in health, whether it's community, whether it's not-for-profits, whether it's the public system, everybody is just running instead of having time to settle and to think and to hear about these new innovative. They're not innovative. If you look at circle healing with Aboriginal people, it's not innovative at all. We're ripping them off again. But it works, but they haven't got time to hear about it. And that's what the issue is. We need to give them time or present it in such simple little ways that they can grab it really quickly and learn about it and be convinced that when they do this, it's going to work for everybody involved.
So, Carline, from a GP point of view.
Yeah, I'm very glad to hear you say let's situate it in general practice, because it is in the community and it's a sustainable model. I mean, it's not a perfect model, but it is community-based and it's small enough that you can form those relationships. And I think the other thing is people don't realise a lot of people are in general practice because they're refugees from the same system that you're talking about is broken. Like someone like me who's got no medical background, I'm just a normal person. Like I was the first doctor in my family. I'm the daughter of a refugee. I've got people with lived experience in my family. I've got 3 or 4 queer nieces and nephews and a son. I understand diversity. I'm just normal. And I work in general practice because the hospital system is, we have to untrain doctors to come and work in the community. And what you're talking about is exactly the healthy model. And we've learnt it from Aboriginal and Torres Strait Islander people. If you can work in that environment and undo some of the learning that you had to learn to become a doctor, then I think the system can work. And it is hard culture change, but believe me, there are people who want to change and want to be part of those systems. And yes, we could fund them because they're actually not as expensive as hospital-based services. Anytime a government wants to build a building that they can cut a ribbon in front of, sorry if you work in Headspace, but to me, that's a waste of money. We don't need buildings and ribbons. We need people who want to work together in the community.
So we should close the public health system and just move it all out? That's what we should do?
I mean, it's not true. They do still have beds there because I've stood there and I've seen them. But
They've actually got more beds than we've got. It's just they don't call them beds, but that's another matter.
Well,
they've got places for people
it's
to go.
very different. It's very
which are not
different to
run
how
like
we
our
work
beds.
with very different attitudes and culture.
I was probably not going to debate Teresa because I could actually ask Andrew, who does work in the public system. You talked about getting like-minded people. But and I think Vicki mentioned, well, there are a lot of people who aren't very like-minded. So how do you get the people to be like-minded, and how do you make that? You said work with people that you like to work with who want to do it.
Yep.
But you don't always have that employment opportunity all the time, do you? So how do you get the whole?
I would probably go back to something that Sam Manga said in his talk, and about the early adopters, and you set a trend, and then you slowly bring the majority along with you, and they'll come and follow. But I was also going to add another comment to the previous question about how do we overcome these problems, and I'm thinking about the sphere of influence of the people sitting on stage on this panel, and we're probably not as individuals going to change government policies or too many straight away, but I think the word that we could use is probably integration, and looking at ways of working together and really reducing those silos. And I know it works because I've seen it work. I've seen it work locally. I know that we have had in-house GPs come in and deliver excellent care. The Keeping the Body and Mind program has got lived experience and all the things. And I've got to say that was a battle to get that to happen. And nod to Tim for your presentation. It's great. I just want to also say that we've got to be very careful with peer work as well. That doesn't get stuck in an old model as well, because that was one of the barriers. We were told, oh no, people, lived experience workers, they're only, it's just to tell their stories, just to share their stories. They can't do this other stuff like keeping people well. And of course, we've worked closely in conjunction with CMOs to run joint programs as well. So I really do believe that is one clear way forward that we do have.
So can I just challenge the panel a little bit? And you said that maybe people here haven't got much influence, but we've actually got a national commission, the national commissioner. We've had Queensland commissioner. We've got other commissioners here. I actually am responsible for a lot of stuff. We had a minister talk.
I was referring to the panel rather than the
What I was
audience.
going to say was, what do you think? No, my question was this: what do you think that equally well as a group should therefore be arguing in terms of overcoming the barriers? What would you be saying, as our collective with all those badges you saw in New Zealand? We've got more badges in Australia than that. What should we be doing? If we had the year of the minister, we get, people want us. We are part of the fifth plan. Fifth plan still exists. It's the way forward in Australia. What should we be doing as that group to overcome the barriers? As well.
Oh, well, there are so many things. I'm going to need 3 weeks again. But one of the things that comes off the top of my head first of all is fixing some of the the MBS stuff and the way GPs are funded, and the ability for chronic disease management plans, like the 5 allied health sessions per year that is across all allied health, is beyond a joke, and that needs to change ASAP. But there are so many things. I'm going to let some other people talk and give their opinion on this as well.
I'd like to hear Vicki on this, because I think from an NGO point of view, what would be the main thing you would take forward in that policy that we'd put, as a big platform piece?
I think it's really about collaboration between clinical, non-clinical, primary mental health, bringing in community or NGOs, people that are working on the ground, bringing them into primary healthcare services and working alongside each other. So again, not that silo, that community mental health are working outside of it and primary health are over here. It's that we come together. And I think one of the good things we're seeing, and we've over the last year or two, are the head to health centres. And I'm saying that NEMI was successful in getting some of those, and one particularly in New South Wales and Penrith. And there we now have primary health in the centre alongside peer workers, community mental health workers, and as a health promotion officer on the ground, I'm in there supporting the implementation of physical health programs that can be run out of that centre to make sure that people are, and we do their physical health prompt at that centre. So if something comes up for an individual while they're visiting or saying hello, the practice nurse is there to address that particular issue. So it really needs to be an amalgamation of the primary healthcare services and the community mental health together. But also, unfortunately, a lot of NGOs, what I see and have seen is that NGOs, when they receive their funding for the federal funding or state funding, whatever it might be, they're receiving funding for the community mental health service to provide, potentially, depends on what programs they're providing, whether it be HACI, CLS services, homelessness services. But what's not included in that funding are physical health services to be part of that mental health service that's been delivered. So therefore, those community mental health services can't actually employ a peer health coach. They can't employ a health promotion manager or officer because there's no funding allocated specifically to physical health within the community mental health setting.
So we need to think about a different way of allocating. That's fantastic. I'm going to give Faye and then Carline a go at this. And then we'll see how much time we have left.
I think the equally well roadmap is, that's something that just needs to be marketed a lot more so that the general population and the GPs and psychiatrists and whatever know about it and can learn more from it. But again, it's back to that time. I have a quote here from our CEO, Mark Orr, about the psychiatry liaison. He says, best thing from my perspective is we are building the capacity of primary healthcare, GPs and practices to better support people's mental and physical health together. I think we add in peer support and that coordination is what's really helping people So I think peers know, we know how badly impacted our physical health has been. Yeah. I know some of us smoke, less and less of us smoke. I know that a lot of us are overweight. Well, I put on 22 kilos in 2 months after being forced on to medication. We know that our physical health is really damaged, and so we know how important it is to take care of that, and peer workers can talk about that in a way with people that's not so judgmental and threatening. It's engaging and it's loving and it's relational, and that's the relationship is where so much healing is done and so much motivation is found. And I think that doctors have been sold a pup, well, puppies are lovely, but doctors have been, they've been told by Big Pharma that they have nothing in their hands to help heal people but medication, and that's just not true. They have relationship. That's where healing really begins, and that's where people can be innovated to do something about their physical health as well, and to take responsibility for it themselves. But this isn't just, we keep on saying it's lifestyle choice. It's about it's not. It's about what's forced onto us as far as medication, that as well. That's a really big clincher that a lot of doctors don't actually want to face up to. And I'm sorry, I know it's really strong to say, but when doctors aren't taking care of our physical health, then I think that's neglect. It's neglect, and they're not meeting their duty of care. When psychiatrists aren't worried about our physical health, it's neglect, and they're not taking care of our physical care. They're not meeting their duty of care, and they must be held accountable. I know you want positive stuff. Well, I'm positive that they must be held accountable.
Yeah, that's positive, no doubt about that. Carolyn.
Yeah, Faye, I don't know if it'll make you feel any better, but in the last week, the number of times I've woken up at 3 a.m. worrying about something, at least 3/4 of those times it's been worrying about one of my patients who might die, and they're mostly people with complex mental health issues, either through suicide.
Makes me feel a whole lot worse, darling.
Well, that's what I'm saying. So I don't want to be negative about it, but I do think people worry about it. But if we're talking about a practical solution, I mean, it is the reality in general practice. The more mental health work you do, the lower your income. I don't know if the MBS is going to want to reform that, because when we got the better access money, and at that time we told government 1 in 5 Australians will experience a mental illness in a 12-month period. We only just got to 1 in 5 Australians having a mental health plan. So I don't think that's over-servicing, but they're all going, it costs too much money and it's not efficient and blah, blah, blah. I think they're scared of that, but there are some simple things, and I should say I'm not speaking on behalf of any GP organisation here, because I'm not personally a big believer in fee-for-service as fixing these problems. And the reason it doesn't fix the problems is because people go where the money is, and they go where the money is because they're a small business and they have to keep the business afloat. They have to pay for all the stuff that goes with running a small business. But imagine if we had a system where some of that money went back to the people who needed it. So a simple thing like, if you've got a serious mental illness and you've had to access mental health service, you're eligible for a health assessment. And the health assessment is just a time-based thing. It's like everybody else, if you're over 45 and you're at risk of a serious illness, you can have a health assessment. If you're over 75, you can have one. It can be anywhere between half an hour and an hour, and the nurse can help do it. If we could do that for everybody with serious mental illness, with a focus on making sure their physical health was holistically cared for, GPs would probably do that, because they're actually getting paid for the work that you're asking them to do. And that's a fairly simple, low-hanging fruit thing that we could easily advocate for, and I can't see it as causing too much harm to the budget.
No, throw peer workers in on that.
And peer workers
Thank
would
you.
obviously be encouraged to be part
Now-
of the funded model. We could set up some pilots in a PHN where, as well as the practice nurse, a visiting peer worker could be involved, and you prove, because that's the other thing we need, like the CC chip model, fantastic stuff, setting in KPIs and actually producing data that shows government, because they won't keep funding things unless they can see something measurable at the end. I know that those of us in qualitative research find that hard, but KPIs that show this many people didn't end up in hospital because we did X, Y and Z would make a big difference to people funding things.
Now, I feel like they've just warmed up. We've got 5 minutes left. We've got a choice. We can give them each 1 minute to say their most important sum up, or we can have one question. What would you like? Panel? Go again? Or one question? One question. Russell? No, I was saying 1 minute. 1 minute for them. Okay. All right, we won't take any questions. We'll just let them keep rolling. So I'm going to ask, just starting, Vicki, you've got 1 minute to say anything else that you haven't said that's the most important thing that you should have said today about this overcoming the barriers.
I think we're moving in the right direction. I want to be positive about it, especially that we have Equally Well in place, which is absolutely fantastic. Russell is saying we're leading the world, which is absolutely brilliant, and we have fantastic representation across the board. So it's really, like, I'm so happy to see, representation from lived experience, from NGOs, especially, because we are the people working on the ground. And being able to identify what the key issues are, but we just need a bit of support and a bit of investment. We're very happy. We're very diverse to work collaboratively with everybody. We can adapt, believe me. We also, as NGOs, we evolve. It's like evolution. It takes a bit of time, but we get there in the end.
1 minute.
Yeah. Thank you.
Faye?
Can you come back to me?
Yeah, Andrew.
One of my favourite holiday destinations is hiking in the Himalayas, and it's interesting because when you hike the Himalayas, you tend to look forward at where you've got to go, and we're talking about some seriously big mountains. You go, how am I going to tackle that? But every now and again, you'll turn around and you look at how far you've come and what you've tackled, and I think there's some similarities here. For what has happened with Equally Well and physical health care in general. There is a really, really long way to go and lots of things that we've got to fix. But if you look back, we've come a long way, and we can talk about that for mental health service provision in general. It's still not great, it's still broken, but it's better than where we've come from. So I think let's keep the focus on the future, but let's remember what we've achieved, and try and remain positive about things, because that's where the energy comes from, the positivity.
Thank you. That's our next conference destination.
I don't think I have anything to add to all that, except to say that thanks for the people who came today with lived experience, who shared their experiences and shared their passion and their rage. And I guess I hope they also share their hope, because sometimes when you've been doing this for a long time, you do sometimes have a deficiency of hope, and there isn't a pill for that, is there, Faye? But there are people who are prepared to come to events like this, and people like Russell who are prepared to lead the way. And I think that's the thing that gives me hope to keep going.
Faye, take us home.
I agree with all of those things. I think I do, like I said on the first day, I do have hope now, and I do, because I could drop off the perch any minute, and I do feel now that I could die, feeling like we've achieved something, we've gotten somewhere, and it's likely that I won't live until I'm old, but it seems as though I'm going to live much older than what I thought I was going to, so which is a really good thing. But I think we come at it from two angles. I think we come at it from the soft and cuddly angle, and let's schmooze everybody in, and it's lovely and hopeful and joyful, and I really think that's powerful and important. But I think that we also do have to come from the accountability side as well, and advertise, publish the outcomes of services, publish when that people aren't doing the right things, but we saw in New South Wales that when we started publishing the seclusion and restraint figures, the number of seclusion and restraints fell dramatically. So I'd love it to be all soft and cuddly and let's move this through beautifully. But I'm afraid that there are naysayers who actually need a good smack over the head with some reality about, and I don't mean that physically, I don't mean, with some reality about what they should be doing and to be held accountable. So love and accountability, well, that's a good relationship, isn't it?
Yeah, it is. It is. So thank you. brings us to the end. I just want to ask you all if you can just join with me once again in thanking our panel. Have been fantastic. So thank you very much. Well done.
I'm just going to take 90 seconds of your time to make an announcement. I'd ask Mal and Dave to come up as well. As heading up the project group, we really just want to acknowledge all the people on the Equally Well Alliance who contribute pro bono of hundreds, probably millions of dollars worth of their time pro bono to this cause, and everyone else here who promotes their time to the cause. But in particular, I want to make a special announcement, and to announce that Mal is stepping down as Equally Well Chair. He's taking on a senior leadership role in the Victorian mental health reforms. Mal's been on our journey with us since Expert Advisory Group in 2015, and has been chairing the Equally Well Alliance, along with Dave, with their lived experience expert, for the last 3 years. And I've got to say, a great partnership as chairs, both of them awesome, and we really couldn't ask for better chairs. And we're sorry to see you go, and we wish you well, and we want to thank you for your contribution, but also announce that you'll be handing over the Equally Well baton to Associate Professor John Allan, who's going to lead us going forward. So we've lost Mal, we've got Dave. What can I say? Love and accountability. I don't know, Faye. But listen, it's over to you to close the conference. And Mal, thank you. And Dave, thank you. You're continuing on, but a special thanks to Mal. Thanks, Mal.
All right. What a big couple of days it's been. It's been absolutely wonderful to have you all here. I think it's really important that we recognise and acknowledge and thank our sponsors that have helped make this event possible. Not at least, every single person who has gotten up and delivered some information, talked to us, included us, helped educate and inform us. I certainly come away from this couple of days going forward with a sense of renewal. It's difficult to work on a single project for years and years and feel like you're making a difference. But it's an event like this that really helps cement the amazing impact that this work has. So I thank you, all of you, for that. Mel, would you like to say some words?
Yeah, not too many, because Lee's really keen for us to get out to the shuttle bus before 3 o'clock. Look, I agree. Thank you all for, first of all, staying around. At the end of a conference, there should be some sort of medal for that, I reckon. I don't know quite what it is. A great meeting, and congratulations to really Russell and Lee, who did most of the work. So thank you very much to them. Yes, absolutely. And to share with David, thank you to our sponsors. It always sounds a bit, you thank your sponsors. Well, things happen because people sponsor them sometimes. It's a good thing. So thank you to them. And they're emblematic, I think, of what's been really nice being part of Equally Well. That is probably the broadest collaborative group I currently sort of am involved with the board and the chair of in mental health, which is a great thing. Brings lots of interesting, diverse perspectives, thoughts and ideas, as should be. As should be. Because there's no doubt if we're going to progress through the combination of love and acceptability. I'm going to think about that for a while now. I like that. We need those diverse perspectives. There can be no doubt about that whatsoever. The message is pretty clear, isn't it? That progressing through one perspective alone, no matter how well informed it may or may not be, doesn't happen. So there's a need for every perspective we've got. I want to thank Russell and Lee for my time with Equally Well Australia. I've enjoyed it enormously. It's actually fun being chair of Equally Well. It's good news, John, as opposed to what you're doing in your day job. No, it's not true. We'll talk later whether it's easy to be president of a college of psychiatrists or Equally Well Australia. We'll talk about that. But I've enjoyed it immensely. I've enjoyed the conference immensely, and trust you all travel well, safely and on time. And look forward to seeing you in Sydney in 2023. Thanks very much.